folks, Kirat Singh, PGY5 resident at Vanderbilt Orthopedics. I'm back and I'm here to talk to you about external fixation today. We're going to first start with this projection of the proximal tibia. It's hard to really say whether this is a AP or a lateral. It is a splinted view, and you can tell that there's significant comminution proximally along the tibia and fibula. This injury is likely open and potentially contaminated. Certainly not a scenario where you want to rush the patient and consider dual plating of the tibia because you can't put hardware where there really isn't any soft tissue. This is a great indication for an external fixator, and that's exactly what was done here. The patient received an X-Fix the next morning, and you can see that some degree of internal fixation was also done, as seen on the fluoroscopic image to the left. You can see some A to P screws placed there. This is to highlight a point that just because you're thinking of external fixation doesn't mean you can't use some degree of internal fixation at the same time. Let me talk to you about indications first. Putting on an X-Fix is a great thing to do. You can do it rapidly, and it's great in a setting of an emergency. So somebody who's a polytrauma patient and has an injury severity score greater than 25, you should start thinking about an X-Fix. And it's probably the safest way to initially stabilize fractures in somebody who's severely injured, especially somebody who's got an ISS greater than 40. You can do this and essentially not damage the soft tissue envelope of the patient. A knee spanning X-Fix really should take only about 15 minutes or so. You can do it rapidly, and you can minimize the inflammatory response of the body in response to this surgery. You really, in damage control orthopedics, want to minimize the iatrogenic inflammatory response that the patient is going to put forth. And what I mean by that is there's the first hit of inflammation that the patient receives, and that is at the time of the injury. So when the person flew off the motorcycle and collided with the pavement at 70 miles an hour, that was the first hit. Or when the 75-year-old guy fell off the ladder and destroyed his proximal tibia, that was the first hit. Your job as a surgeon is to make sure that you don't maximize that damage by rushing them to the OR and then putting on plates and putting a huge whack on a patient and then revving up their IL-6 response, which can really disadvantage the patient. All that to say, a polytrauma patient is a great indication to put on an X-Fix. In scenarios where there is soft tissue compromise, so that can be when the soft tissue is open, sort of a 3B tibia, grossly contaminated where you don't want to put hardware in, or even when the tissue itself is closed, but you can see that the tissue is severely injured. So somebody falling off a ladder will have swollen compartments, and you may not want to put an incision on something like that. If there's an infection, putting pins outside of the zone of infection is another indication to use an X-Fix. When you apply an X-Fix, you should remember that you can use it either provisionally, i.e. it's going to be on for a couple days or maybe a week, or this is something that's going to be definitive, i.e. we're going to have this on for the duration of the treatment. And when you're applying X-Fixes, the stability you're achieving is going to be relative. So this is not an absolute stability construct, and you will expect to see callus should you decide to use external fixation as your definitive method of treatment. Something I'm not really going to talk about in this talk is bone transport and deformity correction, but those are two other indications in which you want to consider using an X-Fix. Other thoughts in general about X-Fixes, the ones that companies are making now as far as the clamps and the rods are MRI compatible. If you don't know, it's a good idea to just go on the website of the manufacturer and see whether the rods will be MRI compatible. Secondly, in the setting of a 3C tibia or any other vascular injury that is requiring repair, it's a good idea as orthopedic surgeons to get in there first and stabilize the bone before doing any kind of vascular repair because the procedure is quick and it helps stabilize the bone so that the vascular repair will be successful and won't be torn to shreds as soon as they're done with it. You can always, like I'd mentioned in the earlier slides, you can always supplement the external fixation with a limited degree of internal fixation, and sometimes in a pilon when you feel like you can make a small percutaneous incision, clamp it, and put a screw across the plafond. That may be a great scenario to put percutaneous fixation, limited internal fixation with the ankle spanning X-Fix. Here up on the screen you can see the half pins. These are available in steel, titanium, and then some of them also have hydroxyapatite coating. The HA coating is good for obtaining purchase in bone and really allows for integration in the bone and prevents loosening. Probably a good idea to use HA coating when you're using X-Fixes as the definitive form of treatment. When you're putting these pins in, think about the definitive fixation. So if you're putting plates medially and laterally and you know your plate is going to be a 10-hole plate and it extends a certain distance from the articular surface, then make sure you try and not put your pins in the same area where your plate is going to go in the future. Additionally, put it out of the zone of the injury. So if there's degloving or a Morel lesion, you don't want to put that pin directly in the side of that zone of injury or zone of infection if you're doing it for infection purposes. You need at least 2 pins per main fragment to gain sufficient control. And if you're trying to increase stability, really the first thing you can do is increase the size of the pin, the diameter. And so the stiffness of that pin is going to go up by 1/4 power of the radius of the pin. So a typical pin used in and around the femur is a 5mm pin. Pins around the humerus will be 4 millimeters. If you're going towards the distal radius, 3mm pins is what you're going to end up using. So increasing pin diameter will increase stiffness. If you can get the ends of the fracture opposed to one another, that also helps significantly with stability. There is a limit to how thick you can go with your pins. You don't want your pins to be thicker than 1/3 of the diameter of the bone because this does increase the risk of fracture. Up on the screen you can see the rods. They're either carbon fiber or some of them are stainless steel. If you're putting these on, know that you can increase the stiffness of the construct if you increase the number of bars, if you make the bars thicker, if you put more bars in different planes, and if you minimize the distance of the bars from the bone. You don't want to put the bars so close to the skin that if the patient swells, you're going to compromise the soft tissue envelope, so you want to leave maybe a finger breadth or 2 finger breadths between the skin and the bar itself. The technique is very simple, but before doing any kind of operative procedure, you should always know your anatomy. It's important to know not just where the nerves and the blood vessels go, but also where the joint capsules are. So a question that I usually like to ask my junior residents is, where around the knee can you put a Chance pin and stay out of the joint capsule as far as the tibia? And a study by Reed et al. A couple years back showed that you got to be at least 14 millimeters distal from the subchondral bone to avoid penetration in the joint and then the risk of subsequent septic arthritis. So know your anatomy, know the neurovascular bundles, and then know the anatomy of the joint itself. Dr. Boyce, one of our attendings here in the orthopedic trauma division, always likes to make very tiny incisions such that the skin can then seal around the pin itself. You really don't need an incision bigger than the pin itself, so using a 15 blade and making a very tiny incision in the skin helps with external fixation placement. Pre-drilling. So this is a time to kind of check your understanding and make sure you know the difference between a self-drilling, a self-tapping screw, and in this case a Chance pin, versus ones that are not self-drilling and self-tapping. It is a good idea when you put an X-Fix on to pre-drill the hole. If you're using a self-drilling, self-tapping Chance pin and you are not pre-drilling, you are going to cause thermal necrosis of that bone right around the site of insertion. Osteoclasts will die, at least in vitro studies, at 122 degrees Fahrenheit temperature. And when you're drilling when you're using a self-tapping, self-drilling Chance pin and you're putting the pin in, that temperature exceeds greater than 190 degrees Fahrenheit. So the idea behind pre-drilling is that pre-drilling takes some of the work out of the self-drilling, self-tapping screw, and so therefore it will not heat up as much. So pre-drill it and then put the Chance pin in. If you as the medical student or the resident are standing by and somebody else is putting the X-Fix on, make sure that you're irrigating to help decrease the thermal necrosis. Again, pre-drilling helps with lowering the temperature. And then using power, believe it or not, actually lowers the temperature as opposed to using hand. The idea there being that when you're putting screws in on hand, the duration that it takes is higher. The time it takes to put that pin in is longer, therefore the bone is exposed to heat longer and therefore the damage is higher. So use power. When you first put the pins on, you want to attach these clamps onto those pins, and you can see those in the on the screen in the lower right. I'm going to walk you through the steps of how to put these in. So first, you put the pins in and you verify how deep you've gone. Verify this on X-ray. So if we were to put an X-Fix on a proximal tibia, you would want to put 2 pins in the tibia, usually 5 millimeters by 150 millimeters in length. You make small incisions, you pre-drill, and then you put these pins in. Once the pins are in, you have your fluoro machine come in and you verify how deep you are. You want to be bicortical. You verify that on X-ray, and then you put 2 pins in the femur. Then you attach the clamps, which again are shown in the bottom right, to those pins. And then you attach the rods. And you keep everything just finger tight. And then you do the reduction. And once your reduction's done, you use the wrench in the top right to get your first tightening done. You take an X-ray. If you like how things are looking, then you do a final tightening. The point I want to make here with this slide is use the wrench shown in the middle to do your final tightening. And that's again because it has a bigger lever arm and helps you get a better tightening of the screw. You'll get asked about pin care. There have been plenty of studies done about what the optimal pin care approach is. There were studies in the past where hydrogen peroxide was recommended. In general, no one method is better than the other. It's okay for the patient to shower, provided that their other concomitant injuries allow that. Soap and water is perfectly fine. There is a method of quantifying pin site and pin site infections. The general rule is that any pin that is loose needs to come out. Loose pins irritate soft tissue, are essentially a petri dish of bacteria, and in fact they've actually cultured pins taken out of X-Fix sites and have shown that over 70% of them are colonized with some kind of bacteria. Sometimes it's E. coli, sometimes it's staph, and at least 30% of those cases show that there's virulent resistant bacteria such as MRSA. So if in scenarios where you're prepping in an X-Fix for a definitive fixation approach, i.e. A patient who's 3 days out from an injury, 2 days out from a knee-spanning X-Fix, and you're taking them now to perhaps plate, and you're prepping in the X-Fix in the surgery, make sure that you see this X-Fix as a roller coaster and a amusement park for bacteria, and so really scrub that down the same way you'd scrub down skin. If you see them back in clinic and there's just a slight bit of erythema, it's okay to treat them with PO antibiotics, again, provided that the pin is stable. If the pin is loose, that pin needs to come out. And there is a classification system for how loose you think the pin is, but none of that stuff is really relevant for this talk. I think as long as you understand that a loose pin needs to come out, I think you'll be okay. Again, these are my classmates, all PGY5 residents. You may see them from time to time. If you have any questions regarding X-Fixes or orthopedic trauma in general, I'd be happy to try and answer them. My email is up there. Thank you.